Now we are starting endovenous glue ablation procedure. Today we are going to use Variclose procedure. We are in the operating room conditions now. The reason is, in reality, we can do this kind of operation quite easily in outpatient settings. For example, I'm doing almost all of time in my outpatient clinic. But because of this training purposes, this time we selected to be in an operating room. This patient doesn't have any anesthetics. We just gave him a very small dose of midazolam in order to keep him cold. Otherwise, this is usually a local anesthetic procedure. Now, what we got in the set is, first of all, we have needle for introduction to the vein. This is very, very usual stuff. There is nothing different at all. Then we have one 6F introducer. We have one 6F introducer. This is usually really very usual stuff. Now, what about the system? How we are preparing the system? We have a gun here. Very efficient, very nice gun. The first step is we have to put this part in, pull it back. Then we have one adapter for the syringe we are going to use. And we are going to fill this injector to here. Then the other parts of the procedure, we have a long guide wire. Then we have one introducer, big introducer, and inside the introducer we have polytetrafluoroethylene catheter. This catheter is the most important part of the procedure. This is PTFE. It's resistant for sticking, and the tip of the catheter is a new design. If you can see, there is a small metallic part at the tip of the catheter. You can easily see. And the other advantage of this system is the glue is not going upwards towards here, not towards the saphenofemoral junction. Instead, in reality, the glue is going to the radial position, like new radial ring catheters. Now I'm going to show you one example how it works. This one is glue, so-called Turkish glue. I'm not going to use this one for the procedure. I opened this glue only in order to show you how the system works and how in this new system the glue is not going upwards, not towards the saphenofemoral junction, instead to the lateral side. I am opening the glue. Where's my injector? Injector is here. I am pulling glue, as you can see here. As I told you before, this is only demonstration to show how glue works. Then I am adapting this one here. Now I want to show you a very good picture of how glue is going. I'm injecting slowly, 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 slowly. Can you see? The glue is coming from the lateral parts, not going to the upwards. Can you see it? In that case, we may be closer to the saphenofemoral junction, and in that case, we can close some important side branches of the saphenofemoral junction, which we usually do in normal surgery. In the meantime, I'm going to show you how efficient is the material. As you can see here, it's very strong stick. It's very strong. So, as you can see, the difference between this new catheter is the glue is not going upwards, not towards the saphenofemoral junction. Instead, it's going to the lateral side. It's very important advantage. After this new catheter, I started to be away only 1.5 centimeters from the saphenofemoral junction. As you know, venous heel suggests 5 centimeters, which is very long. In the other Turkish glues, we used to suggest 3 centimeters. Now we changed the protocol with this new design. We are only 1.5 centimeters to the saphenofemoral junction because this one is going to the upwards. I can't use this one for the patient now. The reason is the polymerization time of this new glue is only 5 seconds. So I opened this catheter for you only to show how the glue works in outside position. Right, now we have to change the system and we are going to start to do the case. This is the all setup we are using. We don't need any important thing. I like to do mini phlebectomy in the same session. You know, many surgeons are doing endovenous truncal ablation first, then wait for 2-3 months, then do again mini phlebectomy or foam, doesn't matter. But I like to do in one session everything. So I like to do one needle. We have some mosquitoes here. No, we don't need anything else. Very simple, very easy setup for the patient. This chap is 38 years old gentleman. He has venous insufficiency for a while. As you can see here, he has hyperpigmentation there. And I did his ultrasound examination previously, and his great saphenous vein is regurgitating. So we decided to do endovenous glue ablation procedure. In reality, in the study we did, the upper limit we used was only 16 millimeters. And as a protocol, in this study, we didn't enroll the patients over 16 millimeters. But in the practical wise, I do endovenous glue ablation up to 20 millimeters. I haven't seen any problem so far. So in my practical day is 20 millimeters is a threshold for the size of the vein. But this patient has a very good vein over there. First of all, I need local anesthetics. Give me local anesthetic, please. Local is there. Then I need needle. I am in. Guide please. This one. Now I am putting 6F introducer in. This one is ready. Now I can prepare glue. I'm going to use 2 needles. One. Hold this one for me. And that one. The color of the glue is very important. You can easily see what we are doing. The airing. Hold this one for me. Now the next step is to prepare the other part. Never ever inject any water in it. Never ever, which is very important. Only you can make a wet swab of this one for me. You can make a wet swab. That's it. Focus on for me. We are filling glue to the system. Connect to that one. And prime. We have to be very careful here. The glue never be on the top. It's very important here. The ideal position of the glue is here. We have to leave some air there. Be careful. Everyone, nursing staff, maviye dikkat etsen de. Çok gitmesin. It's there. I can see. On the screen, you may not see it because, I mean, even with my eyes, I can see here somewhere here the glue. A bit more. A bit more. It's not. It's here. Now this one is ready for the procedure. Keep this one for me. Some water, please. Wait. The next step is advancing the G wire. I have to see the catheter, which I put in so far. Somewhere here. The guide wire is there. The guide wire is there. The guide wire is there. Bandajları alışma sonra. The guide wire is there. The guide wire is there. The guide wire is there. The guide wire is in the deep vein now. So the localization is pretty good. Then I'm going to use this one, introducing catheter. Tip is there. So I can introduce it. Guide wire is off. And I can advance it, bring towards here easily this one. We will check everything later. Everything is ready, everything is under control. Now, the next step is to put the catheter in the best position. There's a lead mount here. The catheter is there. This is whole system now. Saphenofemoral junction. As you can see how beautiful is the position, not position, the view. There's a leaf note here. back the system. The tip of the catheter is not in the deep vein now, which is not important for us. Anyway, we are going to pull it back, except in the saphenofemoral junction now. Deep vein junction. We are in the zero position now. Can you see? I'm sure you can see. We are in the junction now. You can easily see how beautiful is the appearance of the catheter. The catheter. Junction, saphenopharynx. I'm pulling it back only 1.5 centimeters. In this particular patient, I couldn't see except where superior vertical sigmoid is. But anyway, which is not, no, it's coming from there. Yeah, superior vertical is there. I can see it now. Right. From this point, I'm pulling it back 1.5 centimeters. You are going to ask me how. If you can show here, there is a markers here. I mean, as I'm an experienced guy, I'm not looking down. But if you wish, you can bring it in the zero position. Then you can pull it back 1.5 centimeters when using this one. Now this system is almost the same with the laser. We are 1.5 centimeters to the saphenofemoral junction. The next step is the pulling back speed is like laser. Everything is ready now. The system is ready. We are ready for injection. But I need you here, please. She's going to give a saphenofemoral junction. Accept the good pressure here, please. Press out. Now I'm starting to give the material and pull back in the meantime. The aim is to give in a long chip 2 minutes. I can feel a resistance here, which is very good. If I feel the resistance, that means I'm doing my job nicely. In the meantime, I'm checking where I am. Still, we have 10 centimeters there. Giving the glue. It's completely like laser. You know how strong is the material? How strong? I have to make a pressure there. And we are going to check where are we, what we have done, etc. Right. As you can see, deep vein is open. Exactly, you can easily see the location there. Just check 12 o'clock position, the vein is open because we left it open. Then soon after that, the vein is blocked. You can see the glue material there is filling the vein. You can easily follow it. This one is glue. This one is glue. This one is glue. This one is glue. You can easily see there. And this is Mickey Mouse sign. Deep vein is open. Saphenofemoral junction is open, compressible here, but it's closed soon after that. I can't compress here. Saphenofemoral junction going deep, and glue is there. Good procedure. Very small peak here, and the procedure is over. This is the endovenous glue procedure. It's the new designed tip of the catheter, and everything works very well.